Good afternoon. Welcome to today's webinar on taking care of your community, addressing collective trauma in times of crisis. This event is part of a joint webinar series with the National League of Cities and the American Psychological Association. Today's webinar is being recorded. A copy of the recording will be sent to all attendees and registrants. Please feel free to ask questions during today's presentation using the questions box on the dashboard located on the right of your screen. Now I would like to introduce the CEO for the National League of Cities, Mr. Clarence Anthony.
Good afternoon, and thank you all so much for being here today to participate in this important town hall discussion around the issues that we are dealing with in cities all over America right now. And I must say that we recognize that we are in uncharted, uncertain, challenging times. City leaders, the residents, and stakeholders are facing a nearly unprecedented array of emerging and existing crises. Prior to the pandemic, we all recognized that our nation's ability to effectively address mental health issues, especially in communities of color and underserved communities, was lacking. And now demands and needs on systems that are already stretched thin actually increasing daily because of the stress. You know, mental health during the COVID-19 times are really exacerbating, especially among the Black, Indigenous, and Latinx communities, given the disparities in cases and deaths. It's documented triple times for African Americans in certain regions and double that of white communities in the Latinx community. Further adding to the stress and trauma are the challenges associated with police brutality and the murder of Black people across this country, resulting in protests and uprising demanding for racial justice. This anxiety and fear has come about during a time that we have a sense of economic instability as well. There is a range of impacts on our communities, including systems failure on full display and the pressing demand to address the long-standing institutional and structural racism. The reported increases in PTSD among city staff and other essential workers and residents, their stakeholders, the students, our family, all of us, all sectors are being impacted in a very, very stressful manner. Visible despair among vulnerable and marginalized populations are getting hit even harder with the stress of today's challenges. We're seeing increases in violence and trauma, people losing their jobs, specifically city and organizational furloughs, isolation. I can go on and on. And as we look at all of these issues, sometimes we forget other sectors and connecting impacts. So I started thinking about the fact that we've been dealing with extreme increase in the opioid heroin addiction. Just imagine not being able to get to your programs that will support you and strengthen you. Just imagine you're not being able to get away from those stressful moments that pulled you to that disorder. And now you have COVID-19 that creates isolation. That is an issue that we also have to pay attention to as municipal city leaders, nonprofits, because I think sometimes that health failure and that need for that boost, mental health boost, when it's not there, you find yourself back to where you started. So today, we're just honored to have a panel that can help educate us and support us in these difficult times. Because it's a time where we may not be together, but I can tell you we are together around wanting to address the issue of mental health and being able to take care of yourself first. And our panel has a diverse view on these issues from different angles, a practitioner, a local government leader in this space, as well as an association director who has dealt with these issues of behavioral health issues for decades. So I'm going to, I'm honored to introduce this esteemed group. And the first we're going to hear from a little bit later is Dr. Arthur Evans, who's the CEO and Executive Vice President of the American Psychological Association. Dr. Evans has deep experience in these areas as he served as the director of the City of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. The most prominent thing that Dr. Evans has achieved is he was my college roommate, and he survived that, and we're both working together in this space. So it's always an honor to be a part of anything that ACE is doing. We also have Ron Manderscheid, Executive Director of the National Association of County Behavioral Health and Departmental Disability Directors, brings a decades of experience in, as I already noted, behavioral health issues. And finally, on the ground every day, I work with her mayor and city council members. What a great city in San Antonio, Texas. Melody Woosley, Director of the Department of Human Services for the city of San Antonio. And so we are honored to have this esteemed group here today. And Dr. Evans is not going to be here in person today, but because this is so important to him, he has provided us with a video introduction to be able to talk about this issue, and then we'll go to our other panelists.
Good afternoon. I want to talk to you today about the psychological impact of the pandemic and what you can do as city leaders to help your community address the psychological impact of the pandemic. First off, though, I want to thank Clarence Anthony and the National League of Cities for inviting me to be a part of this. And I really appreciate my good friend Ron Manderscheid also doing this and being a part of this. Ron is extremely beloved leader in the mental health community, and I'm just excited that he's here to also help share his considerable knowledge on this topic. So the main message here is, number one, is that you as a city leader are the closest part of government to the people in your community, and as such, you can have the greatest impact on how your community deals with the pandemic and all of the other issues that have arisen out of this pandemic. The 3 points that I want to make are this. It's important to recognize that the pandemic is as much a psychological event as it is a physical event. We've spent a lot of our time and energy on addressing the physical aspects, but as many of you know, this is also a very significant psychological event. I'll talk a little bit more about that. The second point is that you as city leaders can make a difference in how your community deals with and addresses the psychological impact that they're experiencing. And then thirdly, it's important for you to partner with people in your community and within your state who can help you address the psychological needs of your community. So let me take that first point and talk a little bit more about the psychological impact of COVID and the pandemic that we're experiencing. We are seeing significant levels of stress. The American Psychological Association does a survey each year looking at the stress levels of Americans, and we are measuring the highest levels of stress that we've ever measured since we've been doing the survey. We also know from other surveys that Americans are experiencing a lot of psychological symptoms. We know that more people are reaching out and seeking out mental health services. And we know anecdotally from many of our members and from other mental health professionals that, that the levels of stress that people are reporting when they are seeking services is pretty significant. When you add to that the economic downturn, and we know from lots of research that whenever there's an economic downturn, that there is also greater psychological distress in communities. And then when you add to that the issue of race and racism and how the country is dealing with that, particularly for communities of color, all of those things come together to really create a perfect storm of issues and stressors that are causing psychological distress for many people. And we know this. We know that when people are experiencing a lot of stress, and particularly unrelenting stress like we're experiencing now, that it leads to both psychological problems, but also physical problems for people. And those range from issues like substance use and depression and anxiety and trauma-based and traumatic stress to physical conditions like cardiovascular problems and other physical health problems. So it's really important to understand that this psychological impact that people are experiencing is really important to understand and to try to mitigate. So first point is, this is a psychological event. Second point is this, that you as city leaders can play a role in helping to mitigate the stress that your communities are experiencing, and you can play a role in helping to address the psychological impact that, these events are happening. Probably the thing that you can do that is the most impactful is how you communicate to your communities. We know through a lot of psychological research that risk communication, or your ability to communicate in a clear, concise way, for you to be a credible source of information, for you to be viewed as transparent, all of those things contribute to not only how people hear your messages, how they respond to your messages, but can also help to reduce the anxiety that people may be feeling when they get messages that they feel are not either credible, or they're not reliable, or they may be mixed messages with other information that they're receiving from credible sources. So making sure that you are speaking based on the best science and the best recommendations coming from our medical professionals is extremely important in terms of how people will perceive you and how effective you will be as a communicator, but will also help your communities in terms of how they are responding to what's happening. So this is a psychological event. There are things that you can do in terms of how you model and how you communicate. And I will also say in terms of not only your communication, but also how you model taking care of yourself from a mental health standpoint is also can be very powerful, particularly mayors and people who are in leadership positions like that. When you talk about and acknowledge the stressors that you are experiencing and the things that you're doing to mitigate stress, that's really important. Talking about how you give people time off, or how you are giving people the ability to talk about what's going on to them. Those things signal to people that this is an important aspect of how we manage through this crisis, and how and signals to people things that they can do. And then the third thing is this: you can't do it by yourself. Most city governments do not have within their budgets resources for mental health services. You're in city government, you know that. Most often those resources are in the county government, or they are in state, or they're being managed at the state level. It's important for you to know who those people are in your government, whether it's county or state, who are managing the mental health resources, to reach out to them, to partner with them, to make sure that they understand the needs that you're seeing as a city official, and that they are directing and deploying services to the parts of your community and to the members of your community who are at greatest need. It's also important for you to know who the people are in your community who might be experiencing excess trauma and stress. We know, for example, that communities of color are experiencing and dying at a higher rate and being exposed to the virus at a much higher rate, and as a result have a higher mortality rate. And we're seeing that all across the country. It doesn't matter whether we're talking about urban communities or suburban communities or rural communities. We see those inequities, we see those disparities. You should understand as city officials that that does have a psychological impact on your citizens, and that you want to be reaching out to them, talking to leaders in those communities, and making sure that you are addressing their unique needs. So you really should think about some of these questions. How do people access services, mental health services in your community? What if they're uninsured? How do they access services if they're in crisis? Those are all questions that you should be able to answer as a city official, and you should make sure that you're getting that information from your partners in the state or county government, those individuals who manage those resources and can deploy those resources within your community. So this is a psychological event. You have a real important role to play in helping your community to deal with this event. And if you partner with both the people in your community who are being affected and the people within your state or county government who can help you with that, you're going to be in a much stronger position to help your community through this. So with that, I'm going to turn it over to my friend Ron Manderscheid, and look forward to continuing to support NLC in helping address the mental health aspects of COVID and the other issues that you're dealing with as city officials.
Okay, good afternoon, and thank you very much for inviting me to participate. I want to say to Clarence, Clarence is my neighbor. He's on the 4th floor of a building at 660 North Capitol, and we're on the other side of the 4th floor here. So it's good that we're coming together to do this work. So both Clarence and Arthur pointed to the effects of COVID on mental illness and substance use problems, but I want to put this into a little broader context. So for both mental illness and substance use problems, pre-COVID, we're talking about a problem that is probably of the order of 20% of the population during any given year. Our best epidemiology over the last 30 years is very consistent in that 20% number, that within any given year, 20% of the adult population of the US will experience a mental or behavioral disorder of sufficient severity that they would require care if care were available. Say the same thing about children. In any given year, about 20% of children are exposed to these issues, and about 10% of children have very severe issues. We would say they're seriously emotionally disturbed. Both Arthur and Clarence talked to the effects of stress and then how stress generates anxiety and depression and other mental disorders. I want to add to that group the effects of COVID on people who already have a mental disorder or who already have a substance use disorder before this problem occurs. And for many of those people, COVID has made the problem worse. How do we know all this? We know this because use of care has increased dramatically since COVID began. And I know this from, anecdotal data we get from the field. And what the field people are telling me is that our call-ins for services are up about 80% since the middle of March, and 60% of that increase represents people we've never had contact with before in the behavioral health system. We also know that that care seeking is going to continue into the next year. So if you look at national emergencies and problems of epidemics and so on, you can see that there is an initial effect, which we've already experienced, but there's a secondary effect where we would expect much greater demand for services 12 to 18 months out from the beginning of the event. I would, estimate that probably the expressed need for services, the number of people actually coming forward needing services, could easily double from what it was pre-COVID. So we're talking about a problem that's very large to begin with, and one that will become even larger going forward. The other effect of this that's very important is rate of suicide. So rate of suicide is already very high in the United States, and particularly high in certain groups, including minority groups. And for the obvious reason, we're dealing with racism, we're dealing with poverty, and so on. In an epidemic like COVID, we can also expect suicide rates to increase dramatically. And there is basically for suicides about a 12 to 18 month delay in that increase. So we would be expecting that increase to begin occurring in a major way by the summer of 2021 going forward. So there's a huge need out there, and a need that's going to expand even more going forward. Now, how has behavioral health been able to respond to this? I guess the best way I could describe that is to say the behavioral health system, in a very short period in March, converted itself from essentially interpersonal care to virtual care. So literally overnight, we became a field that delivers most of our care virtually. And we're using systems like Zoom systems and others to deliver that care virtually. And we're even approved to use telephones to deliver care now. So part of the issue on that is, well, how effective is that? And we've learned since that time that for many people, virtual care is actually more effective than interpersonal care. And I guess my own theory of why that's the case is because in virtual care, the consumer, the client, the patient is at parity with the provider. The client is not going into the provider's office where the provider's in control, but is at a parity relationship with the provider, either on a Zoom system or on a telephone system. That leads to better self-determination on the part of the client and self-direction in care, which is generally a very important feature of care for us going forward here, and why I think a lot of people do better. Some people do more poorly. I want to go back to adults with serious mental illness again. The adults with serious mental illness need more support than is able to be given virtually on the system like we're on right now. They need to have groups they interact with every day. They need to have people they interact with every day, and so on. So a lot of that is missing in their space right now, and some of those people are doing more poorly. So going forward here and beginning to think about this and saying, what are the implications of this for cities and so on, there are a huge number of implications. One, I think Arthur pointed to in his comments, it's very important to create partnerships to move this agenda. One obvious partnership would be a partnership between cities and their surrounding counties in the delivery of both mental health and substance use care. Very obvious. Another partnership is working with people in the behavioral health community, many of whom would be very happy to volunteer to work with cities if actually asked to do so. When the government, I'll give you an example of this, when the governor of New York asked for volunteers a couple months ago, he, within just a few days, got 13,000 behavioral health providers who offered to volunteer to work with the state of New York in terms of delivering care. Another partnership, reach out, not to forget baby boomers. Baby boomers, for the most part, are retired now, but baby boomers are not couch potatoes. Many baby boomers would be very happy to work with cities in delivery of care, to continue to do some small level of practice in their chosen field, whether it be psychiatry or psychology or social work, and they're out there and they're available for that type of help. And then finally, a very important part of our ability to respond to this growing demand is to convert our systems to electronic care systems. So there's a lot of work going on right now on how we can deliver what I'm going to call lower end services to people who aren't as severe electronically using various types of social media tools. Some of these tools are driven by artificial intelligence. Some of these tools are as simple as apps for telephone, but there's a lot of work going on. A lot of that work is currently being funded by entities like the National Institute of Mental Health, and I think already is playing a very important role. For example, we know that online cognitive behavioral therapy, and cognitive behavioral therapy is a therapy that's noted to be very effective with people who have depression. Online cognitive behavioral therapy is almost as effective as interpersonal cognitive behavioral therapy, all other things being equal. And so I think, there are a number of tools and partnerships available here that can be of help to the cities as they confront this onslaught of need that was very clearly pointed out by Arthur. So my 3 points, there's new need, there's new services, and there's need for new partnerships as we go forward. So again, I want to thank Clarence for inviting me and thank Arthur for being a wonderful colleague all these many years.
Thank you very much, Ron. Melody? You're on mute, I think.
There we go.
There
Can you hear
go.
me? All right.
Yes.
Well, thank you for having me today. I've been excited about this event. I think it's important. We're seeing every day on the ground the impacts of COVID on behavioral health and stress and trauma that's happening with our families and especially our most vulnerable residents, which to give you a little bit of background, the Department of Human Services focuses on improving the quality of life for our most vulnerable residents. And we do that through everything from early childhood education to senior services to homeless services. And we are both a direct service provider and a funder of nonprofit agencies that help us get out deeper into the community to do our work. We have, over the last couple of years, been implementing equity tools that help us determine who are the most vulnerable populations for the services that we're providing, who needs the help the most when we have limited resources, and then targeting those resources to the people that need it the most. And that really has been our strategy, and you'll hear me talk about that more. And so we feel like the key to every human services challenge, to repeat a little bit what Ron was saying about partnership and collaboration, we don't do anything alone. We look for partners. We don't want to do anything alone. So when there's a new challenge or something we need to address, we look to the nonprofit sector, the private sector, other government organizations, the faith-based community to help us do that work, because we know that one organization can't make the kind of impact that we need to address the problems and challenges that we have. And so in the area of mental health, our county and our local mental health authority are generally have the, responsibility for mental health in the community. However, even in normal times, we needed to address behavioral health in many of our programs and populations we serve in order to achieve any level of success. And that need has expanded tremendously due to the impact of COVID-19, and then also compounded by the racial and income inequalities that you all have discussed. And so, with the homeless population, especially the unsheltered, due to the lack of food, information, access to shelter and services during this time, we really, based on CDC guidance, their trauma and their stress has obviously increased. And so based on CDC guidance for homeless, to leave encampments in place, and then with the closure of many of our shelters to new intake, as well as treatment services to intake, we pulled back as a community, as a homeless response system, on outreach. And so we really pivoted to operating homeless hubs for food, hygiene, supplies, hygiene, showers and hand washing stations, information about COVID, really addressing more of the physical health. And now we're seeing the result of that in increases in homelessness, unsheltered, and then in more openly aggressive behavior from the unsheltered population. And so, we are looking at how do we re-gear up safely to begin again trying to work with that population and get them into services. And so virtual is working a lot for us in some of our case management and counseling programs. It's not as much of an option with homeless. And so that's really where we are right now, is retooling, I guess, our outreach efforts to get back out on the street and work with people. Our shelters have slowly started to reopen to intake and some of our treatment services because we can't leave that any longer. We're also really concerned about the impact of isolation on our senior population. As they shelter in place, often alone, we operate senior centers and nutrition sites across the community, and they're really centered around that congregate meal and around activities to reduce isolation among seniors. And so we immediately transitioned to a drive-through meal delivery, and also ask our partners to help us do wellness checks on our seniors. And we get to spend so little time with the seniors as they drive through to get, a couple of days worth of meals, or when we deliver them to their homes. But we can tell that it's impacting them. And so we are trying to implement those wellness check-ins. We have nonprofit agencies that have put content and classes online. Again, though, that doesn't necessarily get to those most vulnerable seniors that don't have access to the technology they need to take advantage of those. And so, we're dependent a lot on the phones with the seniors, and, in a good way, some of them have asked us to stop calling them because we're calling them too much and contacting them too much. So, but we'll pull back a little when we need to, but we'll continue to do that, just trying to stay in touch and understand their needs. We've come across a number of seniors who have talked to us about fraud and abuse they've experienced. That's increased quite a bit. People taking advantage of seniors who are at home and don't have access to a lot of technical assistance or support. So that's ongoing. Also prior to COVID-19, the city was leading and involved in 2 key behavioral health efforts that are now really more urgent than they ever were. Last year, the city, in partnership with numerous nonprofit, faith-based, government entities, private even, created a trauma-informed care coalition. And the idea was to address the impact of adverse childhood experiences on our residents and communities by working with organizations in all sectors that touch children and youth to become trauma-informed organizations. And so we're in the process of setting up a certifying entity and developing technical assistance and training and a curriculum to help organizations reach that, especially schools, people in the education business. But there, you know, when you think about the number of sectors of the community that see children and have the opportunity to spend time with them or assess them, it's important that we don't just focus on a couple of areas. We have to focus on the whole community. And you know, the other one being a pre-crisis system, so that we can intervene ahead of a serious emergency crisis, reduce emergency detentions. And so, like I said, those are both in progress. We are continuing. We've moved forward throughout the entire 4 months to put those things together because we know they're more important, really more urgent now than they were before. And we know that the mental health and substance use impacts of COVID will go on for a long time. So we continue to work on doing that. And then, you know, really there's a number of programs that we're standing up. The city created a COVID-19 recovery and resilience plan, you know, with the idea being all of these funds, federal funds coming into the community, how do we use them in the most efficient and effective way that we can improve our, not just improve our systems, but leave something when those dollars are gone. And so, you know, some of those funds are very focused on either homelessness or recovery, family recovery and financial recovery. And so we're working within those boundaries, braiding that funding, braiding with our private foundations that are also raising a great deal of money so that we can focus on that recovery effort, and that includes mental health. And so really we feel like, you know, maybe the first step in addressing stress, which leads to trauma and down the road, is, you know, helping with the financial recovery piece. And so if people are constantly hungry and they're thinking about how they're going to pay their rent or they're about to be evicted, that stress is just increasing tenfold. And so we established financial recovery housing and recovery centers to help people virtually and physically with that kind of assistance, with really the first focus being how do we help them access every public benefit and resource for which they are eligible? Because we know that so many families aren't getting SNAP or financial assistance they may be eligible for. They don't necessarily always get their earned income tax credit. How do we get them, and how do we layer on every benefit that they can possibly get? We have a risk mitigation fund for emergency rental assistance to keep people housed. And so that's really the first step. These centers are also doing, have created an intake assessment that takes into account their adverse childhood experience score to direct them to the right place and the right service that could include mental health, workforce, or even micro enterprise assistance. So that's really been our strategy in addressing COVID recovery. And you know, I want to acknowledge as well how effective some of the virtual counseling and case management and services have been. We've seen higher appointment retention rates. People are keeping their appointments at a higher rate, and a lot of that we think is because ease of access. Transportation is difficult sometimes for people to get services. Childcare to go and get services. It's just helping enormously, we think, and that's something that'll continue beyond COVID. And so a lot of what we're doing is beefing up our technology, just like everybody on the line is learning more and more about how to manage through video and technology means. And then I'd say the other piece is just looking at equity in every budget and policy decision we make. We look at who does that impact, who does that really help, and if it's not helping the people that need it most, we're not doing it right. So thank you, and I'm looking forward to the questions.
Thank you very much, Melody and Ron, for teeing up a discussion that we are about to have at this point. There are a couple of things that both of you talked about, and I want to start by, you used the word a lot, access, Melody, to services. With dwindling city funds, I know San Antonio is in the Convention and Visitors Bureau area, furloughed employees,
Yes.
and custom employees. Ron, you're seeing that all over America at the county as well as the city level as it relates to the services. So I want you guys to cover two things. Access, how do you encourage city leaders to talk to people about how they have access, whether they have insurance or they don't have insurance? The other piece about this that both of you talked about, there's been an increase. The floor has been 20%, but now there's a higher demand. With these dwindling budgets, how are city leaders going to be able to fund the service? So Melody, I'm going to start with you, and Ron, if you could add on, that'd be great.
Okay, thank you.
Well, I'm gonna go back to my favorite phrase. The people who know me well get tired of hearing probably, and that's that we don't do anything alone, and we don't want to. We look for partners. So the access, the access piece is about finding those partners sometimes that have better access to people than we do, or they're more established in certain neighborhoods than the government or the city is, and that helps us make sure that we're focusing on the right populations. And the resources as well. We've coordinated with a number of our other community funders, and that includes our United Way, our foundations, Bexar County, and looked at how do we layer or ensure that these funds that we've received are being used wisely. We issued for the first time, combined very quick competitive process for our emergency solutions grant funding for homeless services. That included the county, the city, and our continuum of care. And we were able to sit down at a table and say, this one would be better off with the city, this with the county, with the continuum state funding, and put together a group of contracts that we feel like will really help us cover what we need to cover. Part of that also is coming to agreement on how do we spend those dollars, what services are the highest priority. Setting up more shelter or getting people into permanent housing. And so, I think the partnership piece is the most important thing that I can advise is you can't stay in your silos. You have to get out of them and sometimes that means saying, we're not that great at doing this. We think you're better at doing it. And so why don't we fund you to do it instead of trying to do it ourselves?
Okay, so Melody has done a wonderful job talking about partnership, so I'm not going to repeat that ground. I want to go on and talk a little bit about funding and so on. So through several mechanisms, including the CARE Act, funding has been provided to our local providers to deliver additional care, whether that be virtual care or interpersonal care. And I obviously don't have time to go into all of those mechanisms and so on. Some of that money has gone to hospitals. Some of that money has gone to our community providers and so on. So there is additional resources available out there to support these kinds of activities currently. Under the Affordable Care Act, if you are in a state that's done Medicaid expansion, a lot of the people, for example, who've lost their jobs now become eligible for Medicaid. And the state needs to anticipate that this is going to happen, and cities need to make people aware that, whether or not they're aware currently, need to make them aware that they're eligible to enroll in these programs now that they have lost their job, basically. So I think there are a number of mechanisms, and I think the role of the city and the county in this would be to help inform people about these possibilities so that they know they're available. Give you an example here again, New York State also created a hotline where people can call in and get questions answered about care availability, about potential funding of care for Medicaid, about availability of local providers, these types of issues. And as I understand it, that this hotline has been up only a short period of time, but has been very, very successful. I also want to make a comment about needed additional federal help. So you all know that the HEROES Act was passed by the House. It has not gone through the Senate. The Senate is now working on an alternative version to the HEROES Act, and there are two very important numbers in there. One very important number in there is $500 billion of relief for the states. State budgets are anticipating a huge hit of, I would say, 20 to 30% as we move from fiscal year 20 into 21, 22, 23, because of the loss of revenue in sales tax, the loss of revenue by, the system being closed, et cetera, et cetera, et cetera. So the states desperately need that $500 billion. At the same token, counties and cities need $145 billion for the same reason. So the counties and cities lost sales tax revenue and other sources of revenue that they would normally rely on because their businesses were closed for several months. The alternative here is to take deep cuts into services. I don't think any of us sitting here in this webinar want to be talking about, 20 or 30% cuts to our local school systems, to the EMS system, to the behavioral health system, and so on. It just is untenable at the present time. So there's a huge need for advocacy for this $500 billion for the states and $145 billion for the counties and cities to redress the problem that's developed as a result of COVID here.
Melody, I saw you had a reaction in terms of some of that's one great thing about virtuality. You can see almost everything. In regards to the funding going to cities and local governments, did you have something to add?
I was reacting to the piece about the expansion state. Texas is not a state that took the Medicaid expansion, and it's hurting. And we think it's, as people, over 700,000 people in Texas have lost their jobs, and that'll probably continue because we Started out in pretty good shape, and now we're in a crisis. And so we really haven't hit that plateau. We did open businesses around Memorial Day, and they're sort of slowly closing again. So we have a few more months, I think, to go before maybe employment starts to go back up again. But without that Medicaid expansion, we have a big gap in people who have access to healthcare insurance. And while one of the areas that we'll be trying to help with in our recovery centers is identifying medical insurance or some kind of coverage benefit, there's not a lot of options. So that was my reaction.
Okay. So one of the things I want to be able to do is give our participants some models, some examples that have worked that either of you've seen in your city or nationally, because what we tend to see when citizens are dealing with mental health needs, they often are routed through jails or emergency rooms instead of being directed to the services or treatment. And sometimes, you know, it's homelessness or substance abuse disorders. So I'm trying to figure out, what have you seen? What models have you guys seen that have worked? That if city leaders did this, there will be some improvement in terms of use and service and help to residents related to mental health. Ron, you want to start?
Okay, so thank you. So a new thing that has developed in the last several years in the behavioral health field that I think has a lot of promise, and there are examples of this in various places now, are new crisis response service centers. So to the problem that Clarence was talking about, we have had a very significant problem in the growth of the number of people with behavioral health problems who are in our city and county jails. So tonight, there'll be about 730,000 people in the city and county jails. 80 to 90% of those people will be people with primary behavioral health conditions, either mental illness or substance use. That's just totally inappropriate. So the decarceration process and developing smart decarceration says, what can we do in the community to prevent those people from going to jail in the first place? And one of the models that has been developed, and a very good example of this is Washington County, Oregon, right outside Portland, is a county level or a city level crisis response center. And the role of that county or city crisis response center is to be basically open 24/7, to be very unofficious in how it accepts people. You can walk in, the police could bring you, your family member could bring you, a peer could bring you. The main thing is getting you there to get you what you need so that you don't go into crisis. Many of our problems occur because somebody goes into crisis, they are off their meds, there's some crisis in their interpersonal relationships. The police are called, and if the police don't have an alternative, they have no choice but to take somebody to jail. So the purpose of these crisis response centers is to reduce the likelihood that if the police are involved, they will take a person to jail, and even better, not to have the police involved in the first place in these incidents because they, are inappropriate as responders. Part of the reason we are trying very hard, a related issue, to get a 988 national number for mental health is so we decouple mental illness from the 911 call system. When you call the 911 call system, you either are going to have the police coming or you're going to have the EMS people coming. We are trying to decouple mental health from that for the reason we don't think someone who's in emergency mental health crisis should be responded to by the police. So crisis response centers are a very good example, Clarence, of what you're talking about here, and I have shown a good degree of success. A variant of that model is the work that's going on in Kansas. So we held a major meeting in Kansas last fall. We discussed this. The Kansas legislature made the decision they were going to go ahead and create regional crisis response centers for rural communities, because those rural communities and the rural counties simply didn't have the capacity to do this. So they are now in the process of beginning to configure and construct these centers. As we've moved into COVID, the centers, like the rest of behavioral health care, have taken on much more of their function virtually and are doing their work virtually with crisis response teams and so on. So I could go on crisis response centers. I think they're a good intervention tool on the problem of behavioral health persons with behavioral health conditions ending up in jails.
Thank you, Ron. And there's a lot of interest in the chat box of wanting to get more detail about the crisis response center concept.
Okay, good.
Melody, add anything?
Yeah, I'm going to reinforce what Ron just talked about. I spoke a little bit about the pre-crisis center that we're working to stand up, and you know, we believe that that is our biggest gap. As you know, somebody is starting to spiral, or they're out of their medication over the weekend, or they can't get in to see a physician for 4 weeks, then they're going to end up exactly in an emergency detention situation, and most likely in jail, because the emergency detentions generally go to jail rather than to a mental health facility if there's no beds. So that's exactly what we want to prevent. I think Houston has a model, a good model that we've looked at. There are some good ones out there. So there's been a lot of work done on this, and we think it's pretty important that that's where we go next, so that people can walk in, or their family members can bring them, or friends, or even if there's something happening on the street and the police come across them, they can bring them there instead of doing the emergency detention and going to jail. And then our police department also, we have a mental health unit, and that helped for quite a while. But one of the things that they've been doing is we have 3 mental health, qualified mental health clinicians who are now traveling with this unit. So it's a pilot project. And, the goal was to address the highest utilizers, either of the mental health system or the hospital system, find them and keep in contact with them and case manage them, and to reduce 911 calls that were coming in from those individuals or because of those individuals, and then also to reduce the number of emergency detentions. And we're seeing some good results from that. So where the clinician is there and the situation is safe, they're really taking over and doing the case management piece and the and counseling, and then beyond the time out in the field with the officer, they continue to case manage that individual. It's expensive, and the caseloads are low because they need to be, but it's effective. And when you compare that to the cost of putting someone in jail and keeping them in jail, or them being in a hospital setting, it's very efficient and effective. So
Clarence, can I add something? I want to do a shout out for Bexar County and San Antonio. Bexar County and San Antonio were leaders in CIT, crisis intervention training for police, of how to deal with these situations of people who have mental illness or substance use problems. And in fact, some of the best training that's given in the United States is still given in San Antonio. And every police person should have a basic CIT training course, probably 40 hours of CIT training for how to de-escalate situations, how to work with behavioral health providers. And the new model emerging here is the police linked to a social worker in a mobile crisis response team of some type that I think has shown a lot of success. But San Antonio and Bexar County have been real leaders in that.
Thank you.
Well,
And just to add, they actually they get that in the academy now, those 40 hours of CIT training. So it's not even that we have to send people back through. So
yeah, excellent.
I'll have to tell Mayor Nierenberg that you gave him a shout out, Ron. You know, one of the things that's curious to me, and I sort of talked about the disparities as we started this conversation, and the COVID-19 has sort of highlighted it even more.
Right.
What do you guys advise the city leaders do working to address the disparities that I talked to, rooted in race and the stigma of trauma, stress, violence? I mean, you know, you both talked about the fact that in a way, we don't expect police officers to be mental health providers, substance providers, but in fact, they oftentimes have to figure out what they are dealing with. I mean, how do city leaders help to get the tools needed to the community that's being disparately lacking the services, and then also the role of the police officers in this service?
Melody, do you want to start or you want me to start here?
I'm happy to. Yeah, I think it's first really looking at and understanding what's happening in your community. You know, like I said, we've gone through this equity effort that has really shed a lot of light on what's happening, what's happened for decades, and how certain neighborhoods have been underfunded, ignored, and you know, we need to change that. And so it really starts with your budget. Your budget is the expression of public policy. So when you develop a budget document every year, the city is saying this is what we think is the most important thing. And so we're now looking at our budgets department by department we even have a tool called our budget development tool that we put together before we start that planning process. And it really helps you separate and make decisions about how to allocate resources. So I think that's one. And, you know, as far as how do you really get that, you know, work that with the police department, you know, so we acknowledge that, and, you know, police really are the front line for a lot of things, mental health being one of them, because there's so many more of them than there are of us for one reason. And so that's who's out there 24/7. You know, case managers, clinicians, counselors usually aren't out there on the street 24 hours a day. And so we count on the police department to you know, help us identify and point us in the right direction sometimes. There's a lot of discussion about should the police departments be doing these things? Should that be redirected to mental health professionals? And I think those conversations will continue. And there's probably not just one right answer, but I think it's important that every aspect of that is examined. We have a similar set up with domestic violence unit, a crisis intervention team in the police department that addresses domestic violence, where we have caseworkers that go with the police to homes to help the families and help the survivors of violence. And so, I mean, it's a good model, but is it the only model? Probably not. And so I think for us and a lot of a lot of communities, reevaluating how the police are involved in some of these things is important, but the reality is there will always be a large number of officers, and the more that they're trained in the CIT and other things to help be that front line, the better off we are.
Yeah. So I agree with what Melody says. So let me take it in a little bit different direction. So we've known for a long time through our epidemiological work that people in the lowest social class have 8 times the rate of likelihood of developing a behavioral health disorder as those in the highest social class, all other things being equal. And that's been replicated many times over many decades. So that's not a new finding, and it's a consistent finding over time. Having said that, then the issue becomes, why is this the case? Why is this the case that we're seeing 8 times the rate of disorder, in effect, in certain neighborhoods compared to others? And you've all heard the phrase, if you tell me what your zip code is, I'm going to tell you how much money you make, how long you're going to live, and so on. There's huge truth in that, but it should not be true. It should be a false statement. It shouldn't make any difference which zip code you live in, what those factors are on longevity and health and disparities and so on. So if you're going in that direction, you are driven to say, well, I have to begin looking at the factors in my community that generate these problems. So we've come to believe on behavioral health issues pretty much universally that a primary cause of behavioral health conditions for people is being exposed to trauma. So if you are in an environment where you have a lot of exposure to trauma, as a child, as an example, you live in a rat infested house, or you live in a place where there's interpersonal violence going on, including violence against you, sexual violence or physical violence, you are being traumatized. The consequence of that when you become a young adult is you develop a behavioral health problem. So there's actually a scale called the ACEs, Adverse Childhood Experience Scale. And on that scale, if you experience 4 or more of those events before you're 18, the probability is like 96% you're going to have a behavioral health problem by the time you are 18 to 21. So consequence here, going back in there saying, what is it that's going on in the social determinants of health and the physical determinants of health in that community that we can do something about, so it does not become true that that person gets traumatized and actually develops a disorder. So the direction I would take this in as something new to be thought about is asking the cities, what role can your public health people play in helping you think through the whole issue of social and physical determinants of health in your different zip codes, and how you might at least begin taking some initial steps to shut down the front end of the problem. There's a classic example in epidemiology. So should I stand by a river? I'm seeing people drowning in the river, and I should pull them out and save them because they're drowning, or should I go upstream and ask the question, why are they going into the river in the first place? And obviously we need to do both. I think we need to add the second component here, which we don't have in most communities. And there are 1,743 counties in the United States have a county public health officer. The city leadership could be working with the county public health officer who has been given additional resources for COVID and so on some of these very issues that go to the heart of the effects of COVID on the poor, go to the heart of racism in some of these zip codes and so on. It's a very important step to take.
Absolutely.
You guys have really given me a lot to think about related to getting these ideas to our city officials because they truly are interested in addressing this. One of the things I started thinking about, though, is we are talking about cities that have a comprehensive system of service and delivery. But I grew up in rural Florida, and we didn't have, you know, the infant mortality rate and other services wasn't even there because I had to get to that. It could a long ways away. So I think that zip code and the urban rural divide. Any advice for some of our small cities that are out there that are under 10, 20, 30,000 that's saying they're not talking to me right now? Melody, you know, that's San Antonio. What do you guys think?
Yeah, I think that, you know, and I've thought about that before. We have a Head Start grant, and, you know, sometimes when there's discussions about the rural Head Start programs and how many waivers they need because they can't hire the teachers that meet the qualifications, or the family support workers that have the credentials. You know, I think about how difficult that must be to operate any kind of a program. And yet all of the same issues that are in the urban areas exist at some level in the rural areas. You know, I think there are sometimes some multi-county organizations, community action agencies sometimes tend to be multi-county in the smaller, in more rural areas, and tapping into some of those resources. You know, looking for the Council of Governments and working with them on the resources they have and the resources maybe they're eligible for. It is more difficult, and you know, and I think most of the small rural communities really have to reach outside of their community to the adjacent communities, right, in order to effectively use those resources.
Yeah. So add a couple things here. So, you know, for rural areas in the US, we know a couple of important factoids. We know that 85% of the counties in the United States have either no or inadequate behavioral health services. And we know that 63% of the counties in the United States have no access to a psychiatrist, which tells us a lot about these areas. The points that Melody made, I think, are very important. How do you get these smaller cities to work together on a regional basis, i.e. the same as the crisis response centers in Kansas? None of those individual counties in Kansas could solve the problem on their own, but by working together, they were able to create a regional crisis response center that then met the need of all of these areas. I think the same is true more generally, and what we're talking about here is the idea, again, of partnership between these entities in creating regional capacities that don't exist individually. Another part of that partnership that's very important, and something we also did in Kansas, was to say, it isn't just the partnership with your sister counties that are next door or your sister cities that are next door. It's also the important partnership with the state government agencies and the state associations. So we held a big meeting in Kansas where we had the governor, we had the health commissioner there, we had people from the Senate and House of Kansas, and we talked about these things collectively across these different groups, the counties, the state associations, and the state government. It was by building that partnership that we were able to create the concept of these regional crisis response centers in the first place. So the underlying partnerships, again, I think are a very important theme for this entire meeting. And I think they're a very important theme going forward for cities to think about of how they can begin addressing some of these issues. Rural issues have been forefront for us in my organization for a very long time because many of our people in rural areas have the same problems as those in urban areas. They just can't access the services. So there are relatively few providers there. Virtuality can help. Recruiting behavioral health providers from the rural areas originally increases the likelihood they will go back and work in those rural areas. There are a number of strategies that can be employed to help address that.
So let me just tell you guys both, I really appreciate you guys being here. I have learned so much myself that I'm going to use in our information that we'll be providing to our membership as we go through these difficult times. I know Sue Polis in our on our staff has talked a lot about the social determinants of health and how it truly does, and that zip code truly does impact how your life on this earth is and how it the success of it. You know, this is very, very important as we deal with the COVID-19 and we deal with the unrest in our nation. Our leaders are going to have to find ways to access these types of services, no matter who you are in those communities. And you've got given a lot of specific information that's going to be helpful to not only the electeds, but also, I would say, Melody, the staff that are dealing with these challenges. We recognize that there is dwindling funds, especially because of the response that local leaders have got to have to pay for the response that's in those communities. So I want to thank both of you for taking your time to give this information. And Ron, I'll share with Dr. Evans, I'll share with Arthur that you did in fact do an amazing job here today in his place. And we missed him, but he teed this up very well. So thank you guys. And on behalf of the National League of Cities and our partner, APA, we want to thank you for participating, as well as those 100 or some attendees that set in today to hear this information from you guys. Thank you again, and be safe, be careful, and take care of yourselves as well. We need you both. Thank you.
Thank you.
Very good.
Thank
Okay.
you.
Yeah.
Thank you.
Excellent.
Thank you.